friends, welcome to our Academy's next video. I am Dr. Harvinder Singh, creator of Psychiatry Education Forum Academy. So we have a new update from FDA. This medicine, Lumateperone, CAPLYTA, just got FDA approval for Major Depressive Disorder Augmentation. So this short video is to discuss details of that. So I will discuss this very clinically relevant topic in various sections. But before I start, I just want to emphasize I do not have any financial ties with this pharmaceutical company or with any other pharmaceutical company for that matter. So this discussion is all clinical based right now. How can we use this information in our daily practice? That is the goal of this discussion. And I will discuss this in these sections. So number one, we will discuss which are the existing FDA-approved antipsychotics before Lumateperone got approved. Second, we will briefly discuss the mechanism of action of Lumateperone. Third, we will discuss the path this medicine, or I should say the pharmaceutical company, has taken to achieve this FDA approval in terms of which studies were used for this approval by FDA. And then we will discuss how to dose, which drug interaction, and important cautions to keep an eye on. And what are the most common adverse reactions you should keep an eye on and educate your patients before and after starting this medication. And in the end, I will summarize everything, all the key clinical implications for medical professional. So let's start with the first one, existing FDA-approved antipsychotics for MDD augmentations. Now to understand that, I felt the best way to understand is the timeline of the FDA approval of these other atypical antipsychotics for major depressive disorder augmentations. So friends, as you all know that these atypical antipsychotics are not approved as a standalone treatment. I don't think there's any antipsychotic that you can use. All of them are augmentation to the antidepressants. So be mindful of that. So going by timeline, the first medicine in 2003, olanzapine. Actually, olanzapine alone do not have FDA approval. It's the olanzapine plus fluoxetine combination for treatment-resistant depression in 2003. This got the FDA approval. I think it's called Symbyax, right? We all have used it. Theoretically, it makes sense because it's an augmenting agent to an antidepressant, but it's a specific combination in 2003. Before that, there was no approved, FDA-approved medication for MDD from antipsychotic standpoint. So think of this, friends, 2003 and we are in 2025, end of 2025. So 2 decades, right? Before Lumateperone got approval. It's a new medicine, but let's, so 2003, olanzapine plus fluoxetine. In 2007, aripiprazole got the approval for this indication. 2 years later, quetiapine XR got the approval. And then few years later, brexpiprazole 2015 got the approval, followed by last year, 2024, I think it was December if I remember, cariprazine got the FDA approval. And we did post it about this medication. You can check our YouTube, or you can go to psychiatryeducationforum.com/cariprazine-MDD, and you can watch this video on cariprazine when it got approval last year for MDD augmentation. But the other chapter I did for Academy was role of cariprazine for anxious depression. The reason I'm talking about this, friends, is the studies that were done for Lumateperone. I believe many patients have comorbid anxiety disorder, so it showed benefit there as well, although it was not specifically tested for that. So just keep that patients with MDD and comorbid anxiety, cariprazine have shown data among atypical antipsychotic, and Lumateperone was promising as well. Now, So this is what we have learned so far, friends. Aripiprazole, quetiapine XR, olanzapine fluoxetine combination, brexpiprazole, and cariprazine have the FDA approval. Now, I did a very detailed lecture series for Academy members on MDD augmentation series. One of the section was on atypical antipsychotic. I will talk about that in the end. But in that section, we have also talked about other off-label medications like risperidone, for example. Very good data, but it's not for some reason FDA approved. We talked about all that in those lectures. But these are all on label, like all FDA approved medication. And now, going back to that timeline, 2025, November, Lumateperone, CAPLYTA got the approval. So this is the announcement by Johnson & Johnson about the FDA approval on their website. And so this is the sixth medication now, sixth FDA approved medication to achieve or receive the FDA approval for this indication. So this is our section number 1. Now, let's understand what is the likely mechanism of action for lumateperone. So we all know, right, lumateperone comes in atypical antipsychotic, not the typical one. And atypicals have impact on dopamine and serotonin 2A. But lumateperone is a little bit different in terms of mechanism of action. So let's talk about that very briefly here. So the first action is on serotonin with this medication. And this medicine is, it has highest binding affinity for serotonin 2A receptors, friend. It's a serotonin 2A antagonist. And antagonism of serotonin 2A receptor is theoretically known to be associated with increase in dopamine and norepinephrine release in the cortical regions, which is thought to contribute to improvement in mood and cognitive function. And there is so much evidence which suggests that when you combine antidepressants with serotonin 2A antagonism, it will show or offer superior efficacy and more tolerability compared to SSRIs alone. Now, I know one of the antidepressant with serotonin 2A antagonism is, I believe, mirtazapine. But most of these atypicals, or not most, few of them works through this serotonin 2A antagonism. But for lumateperone, compared to dopamine, it has more affinity for serotonin 2A. And other thing is, it works like a SSRI. It's a serotonin reuptake inhibitor with more affinity for serotonin 2A receptor than the dopamine 2. So I always think of this. I was not able to find some data on this, but when we combine SSRIs with lumateperone, I think theoretically it makes sense to keep an eye on serotonin syndrome-like symptoms if this is also working on reuptake inhibition and increasing the availability of serotonin. So that's number 1 action on serotonin, which is serotonin 2A antagonism and reuptake inhibition of serotonin in the neuron. The second impact is on the dopamine, friends. Now, this is very interesting. It works on presynaptic and postsynaptic dopamine 2 receptors. The presynaptic dopamine 2, it's a partial agonist. And for the postsynaptic D2 receptor, it is an antagonist. Now, this is really important because presynaptic D2 receptor act as an autoreceptor, which is like a brake. If you activate it, like that regulates the dopamine release. And partial agonism at this presynaptic site can stabilize the signaling of dopamine. And it potentially is known to enhance the dopaminergic tone in 2 pathway, mesolimbic and mesocortical pathway, which is implicated in the mood regulation. And let me actually move forward. But it has moderate binding affinity compared to the serotonin 2A. I'm repeating it. It's a really important thing to be mindful of. And then it is also a dopamine 1 agonist. It indirectly works on the dopamine 1 receptor, which is known to likely enhance the prefrontal glutamatergic activity. And I'll talk about that in next slide. But the action on the glutamatergic tone is actually done through the dopamine 1 receptors. And that's when our third neurotransmitter of glutamate comes into picture. So it enhances the glutamatergic neurotransmission indirectly through the dopamine 1 receptor agonism. And then it has very minimal impact on histamine and the muscarinic receptors. So friends, this is the basic mechanism of action on how lumateperone shows its effects. Now going to the third topic is how did lumateperone got this FDA approval for MDD augmentation? But before that, friends, we need to know something. We need to know what is this medication initially indicated for or got approval for. So we all know in 2019, it got approved for schizophrenia in adults. And then few years later in 2021, it got approved for bipolar depression as monotherapy and as an adjunct with lithium or valproate. And we actually published a video and chapter on this. If you want to learn more, please go to psychiatryeducationforum.com/lumateperone-bipolar. But the third diagnosis is now in November 2025 as an adjunctive therapy for antidepressant for MDD in adults. All these three diagnoses are for adults. Number one, schizophrenia, it's a monotherapy. Bipolar depression, it's monotherapy and adjunct. But for MDD, it's not a monotherapy. It's only an adjunctive treatment. So now let's understand this MDD. That is what this lecture is about, right? So how did FDA approve this medication for MDD augmentation? They actually used two studies for that. I will talk about three here, but these two studies were phase 3 double-blind multi-center placebo-controlled trials, and they called them study 501 and 502. So after the study was completed, 502, there was a study 503, which is open label study done for 6 months. These two are 6-week studies, friend. So like high quality study, double-blind placebo-controlled multi-center. Let's see the results briefly so that we know what to look for. And I'm not going into full details of the study. I will just take out the important point for clinical standpoint. Number one, so these were 6-week studies, right? So at the end of 6 weeks, they look at change in MedRS, which is a depression rating scale, change in the MedRS total score from baseline to 6 weeks. And these studies have two groups, friends. First was the CAPLYTA, which is lumateperone combined with antidepressant. This is our main goal. And second was placebo combined with antidepressant, right? So antidepressants were there. So in this first study, you see from baseline, from 0 day to 6 week, MedRS score decreased by 14 points, whereas for antidepressant, it decreased by 10 points. And there was a difference of 4.9 with the good effect size. And the second study had similar thing. Like CAPLYTA antidepressant group, same 14.7 reduction, and very close with the antidepressant alone, 10. So same separation of 4.5 to 4.9, and this was statistically significant. So good results from both studies, right? That's why FDA approved it. I'm only using MedRS data, but the studies also showed, I believe, the CGI index, impact on functioning. They also showed improvement. But MedRS, this was the primary endpoint. And the second thing to know is, this is a 6-week study, but how early did the CAPLYTA lumateperone group separated from just the antidepressant plus placebo group? In the first study, it's separated by week 1. That's so interesting to see. In the second study, it was by week 2. So definitely in that week 1 to week 2, you start to see the separation. Something to be mindful of. You can keep an eye on or educate your patients on that. And then they also looked at response rate and remission rate, and how they defined response rate is when MedRS scores reduced by 50% or more from baseline. Now, for the first study, it was 46% response rate and 40% here. But the remission rate, which is reduction in MADRS below 10, it was 26 and 25 for both studies. I know the number looks low, but for medications, we can hope for something close to that. But the interesting thing is, friends, study number 503, which is open label 6-month follow-up study. They had high retention rate, like people stayed, I think 85% retention rate, and they looked at the response rate there after 6 months and remission rate there, and this is what they found. After 6 months in this study 503, response rate was 80%, but remission was impressive at 65%. This is what I found very interesting, so I just included that in that small column there. And now interesting thing is this. The baseline MADRS score was 30 for both studies. What that means is, it's a mean. 30 is mean, that means there's a range, but all patients had moderate to severe depression. So MADRS score is used to stratify your severity of depression as well, like we do with PHQ-9. But 30 is in that moderate range, but when you look at full, it's a mean, but look at full range, it's moderate to severe. So the clinical points I see from my side is, and actually all patients have failed at least one antidepressants in this study. The inclusion criteria was that. So the lesson here is, if a patient has failed 1 or 2 antidepressants, they have moderate to severe depression, they are on antidepressant, you can add CAPLYTA, you can expect to see results within 1 to 2 weeks. You will start to see the separation, and keep this timeline in mind. In 6 weeks, you can expect 40-45% response rate, 25% remission. But if you can continue it for longer, then it increases with that. Now, let's go to the next section on how to dose this medication, what drug interactions to keep an eye on, and important cautions when you prescribe this. Now, dosing. This is the one thing I really like about this medication personally. Let's talk about that. The standard dosing is, this medicine is available in 3 doses, friends. But the most common is 42 milligram once daily dosing. You can give with or without food, doesn't matter. And the lovely thing is, there is no need for dose titration. You just give 42 milligram and that is the standard dosing. I felt this is very helpful for patients and saving time compared to other medications. So 42 milligram once daily dosing is your go-to. But if a patient is on certain medications, then you need to be cautious of the dosing, friends. And this is where the drug interaction comes into picture. And for one thing you need to know about drug interaction with this medicine is cytochrome 3A4. That is what metabolizes this medication. So if a patient is on a 3A4 inhibitors, and there are strong 3A4 inhibitors, and I will talk about moderate 3A4 inhibitors, you need to be mindful. For strong 3A4 inhibitors, you need to use the lower dosing of 10.5. So 10.5 is the lowest dose available, and 42 is the highest dose available. And some examples of strong 3A4 inhibitors are, from a psychiatric standpoint, I think there is only one, nifazodone. And non-psychiatric medications are like this antifungal medication, ketoconazole, etraconazole, and then antibiotics like clarithromycin, and then antiviral medications like lopinavir and ritonavir. But for moderate 3A4 inhibitors, you need to use the middle dose, which is 21 milligram. And examples among antidepressant, I think fluvoxamine was the only thing I found, which is a moderate 3A4 inhibitors. Then antifungal fluconazole, antibiotics, ciprofloxacin, erythromycin, and then diltiazem is moderate inhibitor. And interesting thing is grapefruit juice is a moderate 3A4 inhibitors. So be mindful of that. Now in terms of caution, there is one important caution with this one, which is hepatic impairment. If a patient have moderate or severe hepatic impairment, you use a 21 milligram daily dosage. Now, there's a diagram I used actually when initially, interesting story is, Lumateperone initially got approved for only 42 milligram, but later on they approved 10.5 and 21 milligram for this reason. And when it got approved, when these two other dosings got approved, we created a slide, and this is a slide that I use in my mind when I discuss which medicine to use. So keep this in mind. So there are three doses, right? 42 highest, 21 middle, 10.5 in the lowest one. But 42 is the recommended dose, like we talked here already. And for moderate 3A4 inhibitor, you use 21 milligram. For strong 3A4 inhibitor, you use 10.5. And patients with moderate or severe hepatic impairment, you use 21. So keep this diagram in mind, friends, when you're choosing the medication. So this is a very basic overview of how to dose this medication. Now, very quickly, let's understand what are the common adverse reactions seen in these studies that you can educate your patients for. Now, most common adverse reaction is diagnosed as incidence of 5 or more % and at least twice that of placebo. That's a definition of this. And there are 6 common adverse reactions they found, and I have divided them into 3 on the left, 3 on the right. 3 on the left are more neurological, or you can even call them cardiac symptom, and 3 on the right are more GI symptom. So let's talk about them quickly. The first one is dizziness, second is sedation, third is fatigue. You can always say fatigue, sedation, very similar, right? But they all are very common. And then GI symptoms are dry mouth, nausea, and diarrhea. Now let me move everything to the left right now, and let me show you the direct result from the studies. So you can see, interestingly, headache was on top, but I was not able to find why. Oh, I think I know now. So, one of the definition is incidence should be 5% or more. It's 19%, but it has to be twice that of placebo. Placebo was 13%, so I think that's why headache is not mentioned here, but it's common, friends, so keep an eye on that. And then dizziness, dry mouth, sedation, nausea, fatigue, diarrhea. And then the one below 5% were tremor, vomiting, vertigo, and insomnia. So keep an eye on that. Now, let me go back. The other thing you will ask me, because whenever antipsychotics are discussed, we always look at metabolic side effects, right? Weight gain, cholesterol, lipid panel. We look at the impact on the heart, sexual side effects, prolactin, so many things. Let's talk about the metabolic profile. It has very favorable metabolic profile. We have known this even before when it got approved for schizophrenia. Now, based on this study, patients who gained weight 7% or more, they were same in CAPLYTA and placebo-treated group. So no big difference. And it has minimal impact on glucose and lipid parameters. So something that will actually, that we cannot ignore, right? Because this is one of the important things I personally keep my mind on when I choose the medication. So very favorable metabolic profile. The second thing is the side effect on movements, EPS or tardive dyskinesia. It has favorable movement, favorable on sexual side effect, and they found akathisia risk was less than 1%, sexual side effect risk was less than 1%, because it has lowest risk of prolactin elevation. Now, in terms of prolactin elevation, I just published a full course on our academy. If you're not an academy member, you can join this course for a small fee, but for academy member, this is free. Here, actually, I discussed so much about prolactin elevation, and one of the chapter was ranking medications, ranking antipsychotics actually for prolactin elevation. And their lumateperone was low. But now it all makes sense why lumateperone is low based on the data we have seen so far. Now, coming back to this slide, these are the side effects we need to keep an eye on, friends. Now, I will summarize everything now. Clinical implication. I already mentioned it, but I will go very quickly. Ideal patient selection is it's appropriate for adults, obviously, not for adolescent, not for kids. Adults with MDD who have tried 1 or 2 antidepressants with inadequate response for adequate dose and duration in the current episode. and the dosing is 42 milligram once a day with or without food. No titration required, but cytochrome 3A4 drug interaction to be mindful of. Check baseline liver function test because of moderate to severe hepatic impairment and need for dosage adjustment to 21 milligram. And you continue antidepressant at a therapeutic dose. It's not a standalone, it's an adjunct to antidepressants. And then when you're monitoring, you monitor for these side effects that we already talked about. The package inserts also talked about suicidality. You need to monitor for worsening of that. So keep an eye on that. Now I will end this with key clinical implications for medical professionals based on what we have learned so far. First, it's a new adjunctive option, like 6th FDA-approved adjunctive option among antipsychotic for MDD. 42 milligram once a day, no need for titration, number one. Number two, we have found that it provided a clinically meaningful efficacy, right? Based on study 1 and 2, there was a separation of 4.5 to 4.9 points in MADRS decrease with good effect size, and the remission rate at 6 months approached 65%, which is highly encouraging. And then it has favorable tolerability profile, minimal weight gain, minimal metabolic impact, low sexual side effect burden, low EPS burden. So that places it high on our list when we have to choose among atypicals. And then this is what I just said, the side effect profile places it on a very high right now, and high remission rate is supported by that study 503, which is actually an open label study though. So that is the last point, that it's not a standalone treatment, it's an adjunctive treatment, but acute data, 6-week study, perfect, good data. But we need controlled long-term relapse prevention data, which is still pending right now. I know they will publish once this data is out. But friends, this was a very quick overview. I know it took close to 30 minutes, but I think this was needed. And I will say, I published a very detailed lecture series in our academy on major depressive disorder augmentation strategy. But with this new updates, there is like new data coming into picture. And in this augmentation strategy section, I discussed not only atypical antipsychotic, but all the other medications. And I did not discuss my personal opinion here. I summarized all the studies and extracted the data that we can use in our daily practice. And now with this new information available among antipsychotic, I have added few more information there. But this chapter, I have compared all the international important guidelines, comparing their recommendations for use of antipsychotic. And then I have compared international guidelines with FDA indication. They do differ. And then I have summarized them into first line, second line, third line. And then I have discussed, can low dose antipsychotic help as an augmentation strategy? And what are the recommended doses for each atypical antipsychotic? Then we have discussed individual medication with focus on quetiapine. Which one is recommended, XR or IR? And then I have compared atypical antipsychotic with lithium. Very interesting discussion. I personally loved it because I used myself in my clinical experience. And then this lumateperone role is added there, what you have just heard right now. And in the end, I have ranked them into first line, second line, third line. So I will recommend, friends, if you are interested, please join our academy membership. It's actually all clinically relevant topic. This is just a brief touch that you saw today, what I discussed. And this is how I create these lectures. And these lectures are more for me, personally speaking. I learned through this, but goal is to help others, mainly busy clinical professionals like myself. So please, if you're interested, go to psychiatryeducationforum.com, learn about this, join our academy membership. But if you don't want to join, go to Psychiatry Studio on the top menu. There are few courses I have released, which are for small fees for non-academy members, but academy members get them for free. If you want to join those, see what I do, and if you like, then you can join the academy membership as well. But thank you, friends, for listening to me. I hope this was clinically relevant. I will see you in our next discussion. Till then, you all take care and bye for now. Thank you.